Good morning, Dubai. It's evening here in Minnesota, but we'll work it out. I'd like to thank the folks at Scientex Conferences for inviting me to give this talk for Spine 2022, the Global Congress on Spine and Spinal Disorders. My talk today is our experience with conventional fluoroscopic guided selective cervical nerve root blocks in our experience of safe, effective, and efficient modality in the hands of an experienced proceduralist. Get my screen sharing here, right? All right. I have nothing to disclose. Conventional fluoroscopic guided selective cervical nerve root blocks are commonly used as a treatment for cervical radicular pain. Goal: identify any major complication and determination the safety and clinical utility of selective cervical nerve root blocks guided by fluoroscopy performed at a university hospital and outpatient clinics. Although there are a lot of possible adverse events, the most concerning and potentially catastrophic would be inadvertent arterial invasion with potential for dissection and or inadvertent injection of corticosteroid intraarterially, with either things potentially leading to embolic infarct of the brain or spinal cord. Just a few examples of some of the papers that have been put out discussing this. Death during transforaminal epidural steroid nerve root block due to perforation of the left vertebral artery. Should we discontinue cervical nerve root blocks? Case report, 2 case reports and a review of the literature. Cervical transforaminal epidural steroid injections, more dangerous than we think. A cervical anterior spinal artery syndrome after diagnostic blockade of the right C6 nerve root. Spinal cord injury by direct damage during CT-guided C7 transforaminal epidural steroid injection. If you look through the literature, there's a smattering of both catastrophic events with both CT guidance and fluoroscopic guidance. It doesn't seem to be selective for either one. How do we mitigate the risk of injury during a selective cervical nerve root block? There's a few techniques that we use at my institution. First thing we do is you look at the imaging provided before you start to get what is called the foraminal angle. And that's just basically a measurement of the angle created by the neural foramen. As you note, the vertebral artery is anterior here. When in our institution, we require either an MRI or a CTA of the neck or a CT of the neck with contrast before we'll do a cervical nerve root block or injection, because we need to see where the vessels are. Another mitigation technique is the use of dexamethasone. I think most people are probably using dexamethasone now and not the particulate steroids like methylprednisolone or betamethasone. Empiric evidence shows non-particulate steroid use can prevent neurological complications. In this study, they directly injected dexamethasone into the vertebral artery of pigs and had no adverse events. Another technique is to use a shorter needle. I've discovered over time, initially I started in my practice using a 3.5-inch needle like I'm sure most people use. But I eventually realized there was a 2-inch 25 gauge needle that I could use instead. And in the vast majority of patients, this easily reaches the neural foramen. So it's also easier to steer and easier to locate, and in the posterior inferior corner of the neural foramen, which is the ideal location. You may have to use a 3.5-inch for patients with thicker necks or some of the lower neural foramen. But most of the time I get away with a 2-inch needle. Another mitigation technique is the use of 2 short low volume tubings that I inject the contrast through. And then they're separated after the contrast injection in the middle. And that way the hub is not disturbed when you're connecting the medication syringe. It basically prevents movement of the needle tip after you've already established the appropriate location with contrast injection. The most important thing the most important advantage that conventional fluoroscopy has is the ability to do a live injection. So you step on the pedal and then you start injecting. And what you're looking for is vascular filling, obviously, like this. Now, these are veins and really present no real danger, but of course you don't want to inject in a vein because then you're not putting the medication where you want to put it. But this is a good example of vascular filling. Now, CT versus conventional fluoroscopy for guidance for safety. There's a trend in the literature that was suggesting that CT-guided cervical nerve blocks allows for improved safety and efficacy by way of better needle tip awareness. However, it's our position that using fluoroscopy, when it's performed by an experienced proceduralist, is more safe than CT due to the ability to view contrast injection live and assess for vascular filling. Nobody should be performing these unless they're experienced already doing lumbar injections and lumbar transforaminal injections. So you're used to guiding a needle into a very small space. It's just bad form to try to do this if you're not experienced, and you're going to end it up with problems. So that's where they are feeling that you should be experienced before you even try these. So the technique of the procedure, like I was stating, you measure the foraminal angle, which you'll then use when you're rotating your image intensifier into the appropriate position. And then you're going to want to place the needle posterior inferiorly. So on a conventional fluoroscopy table with a portable C-arm, the C-arm doesn't rotate far enough towards you, so you end up having to oblique the patient. So then when you establish the AP position by rotating the C-arm until you can get the spinous process centered in the spine, you have the technologist look at the angle that you're at, and that becomes your 0 or AP. And then you rotate the C-arm back the number of degrees that the foraminal angle indicated. So if this patient was truly at 45 degrees and the foraminal angle was 50, you would rotate back from the 45 degrees to 0, then add 5 more towards you. And when the proceduralist is standing on this side, and that's what you would, that's what your picture would be, and at that angle. This is another option to have the patient positioned supine, which makes positioning the patient better or easier because their spine is lined up automatically. When they're in this position, their head has a tendency to lean or drift down, and you have to support it. You have to buttress the head on the side to support it so it doesn't rotate when you're doing the procedure, because obviously if you've measured that angle at the appropriate level that you're going to go, you don't want it changing during the procedure. In that sense, this positioning is much better. This is a little bit more challenging for the proceduralist, however, because the image intensifier gets into your vision, and you have to raise the table and the C-arm up in unison. So you have to have this set up where you have a C-arm and table that you can raise at the same time, and then you can bring them up to eye level, and you can do the procedure. I personally prefer this because it takes seconds to get the patient positioned, where this one can take some, fiddling around to get the patient in the right position so their spine is straight and your angle of measurement is going to be consistent. So then once you've got the appropriate foraminal angle positioning, this is what the appearance of your neural foramen. You get a nice view like this. And so when you're going to mark the spot, I use a curved clamp, I just prefer them. you place it gently on the skin. You don't press it into the skin, because you'll discover if you press it into the skin, you make a mark there, you release the clamp and the skin recoils, and your mark is not where you originally thought it was. It's in a different position. It'll be like right over here or over here. So you just gently place the clamp on the skin and make a mark. Then you check it again with the clamp after you've made your mark. And again, the preferred position, the ideal position, is posterior inferior in the foramen. The reason for the inferior positioning is that over time I've noticed that with degenerative changes or just the normal course of the vertebral artery, as you go further up in the foramen, the vertebral artery has a tendency to center in the neural foramen rather than being anterior. And so I've just chosen this location as a safe location, and I use that consistently. So for anesthetizing the skin, I use a 5 ml syringe with a 1 or a 1.5 inch 25 gauge needle, not a 2-inch needle, because if you use a 2-inch needle, you'll end up in the neural foramen if you go all the way in. And it contains a 1% lidocaine solution. You align this parallel to the X-ray beam. I'm sorry. Okay. You align this with the X-ray beam and you advance the needle all the way in and then do a test aspiration. And as you withdraw the needle, you're slowly injecting the lidocaine and it's infiltrating into the tissues, and you infiltrate all the way through the skin. And it says raise a small wheel, but in reality, you almost really don't even need to raise a wheel, because if the lidocaine squirts out as you're going back through the skin, enough's gotten into the skin that it'll be anesthetized. If you try to raise a wheel first, that causes pain to the patient, and they have a tendency to move. Where if you just go in with the needle and you tell them not to move and then infiltrate slowly on the way out, the wheel on the way out doesn't hurt very much, because you're not trying to raise a big wheel. So utilizing either the 2 or the 3.5 inch needle, these are the images you'd want to see. This is the ideal position for the needle. Obviously, it's got a target sign and it's right in the inferior posterior corner. In reality, does it always look like that? No. But you may have to move the needle up depending on your contrast injection. You may have to move it up in the foramen a little bit. It's okay to be up a little bit, but like I said, ideally I want to put it down here. It doesn't always end up perfectly in that position. How far do you advance the needle? You just advance it to the edge of the lateral mass on the AP projection. Initially, when I began performing these, I didn't really have solid teaching, and I was learning a lot of this as I went along. And I would put the needle in a little bit further. And my discovery is that the further you get into the neural foramen, the more likely you're going to get in a vessel. So I stopped right at the edge of the neural foramen, and the vast majority of the people that were in the study had this needle positioning. Initially, there were a few patients that may have been this far in, but you don't need to go any further than this. So once you get to that point, and the way you do this too is you get in this position, in your oblique position, you get your needle lined up, you triangulate, you don't use a clamp to guide the needle, you just use your fingers, and you triangulate and advance the needle a little bit, and keeping it in this position. And then at a point where you're feeling that the needle's in a little ways, then you want to check your AP to see how far you're in. And then you go back and you advance a little bit more, and then eventually you'll get to the point where you're able to advance it, and it's just to the edge of the neural foramen. So at that point, you remove the stylet, you connect the contrast syringe, which is connected to 2 short low volume extension tubings. And they really are low volume. It's like 0.15 mil in each one of them. They're in tandem to the syringe containing the contrast, and you attach the extension tubing to the hub of the 25 gauge needle, obviously stabilizing the hub. So again, there's the picture that shows me stabilizing the hub of the needle and then connecting the tubing with the two tubings attached. So injecting live is important because you want to look for vascular filling. You also want to look for epidural extension. You don't want either of those. Epidural extension you don't want because you're going to be injecting lidocaine and C345, keep the diaphragm alive. But there's also a chance that if the contrast or injection were to go, or well, the medication were to go more inferiorly to around the C8 and T1 nerve roots, if you anesthetize those, you can end up with a pseudo-Horner syndrome. So you perform it under live fluoroscopy and test for vascular filling, which could be missed if the contrast is injected and then the fluoroscopy is activated. Now, this would be ideal if everyone looked like this, because you can actually see the contrast outlining the nerve root here, and it looks great. The vast majority, however, look just exactly like this, where the contrast just kind of flows along the nerve root sleeve. Either one works. It doesn't matter. It doesn't matter what it looks like, as long as it's following the nerve root sleeve, it's fine. So once you've done the contrast injection, then, as I said before, you separate the tandem tubing in the middle, leaving one segment connected still to the needle. And you never, at this point, you're never touching the hub of the needle, so you're not going to advance it, you're not going to move it. And you connect your medication syringe. And in the syringe, there's a cc of 10 milligram per mil dexamethasone and a milliliter of 1% lidocaine. And you leave a little bit of air in the syringe because you're going to use that to chase the medication that's in the tubing down there. This is not the position I inject in with it parallel like this. I just had it in this position for the picture. But when I start to inject, I have the plunger elevated, so the air floats anti-dependently. And then, like I said, you're injecting medication and then you chase it with air up to the hub. You inject slowly, obviously, like any other epidural injection. You don't, rapidly inject. And like I was talking about the air, you'd use it to chase the medication until it's into the hub of the needle. And at that point, as soon as the medication goes into the hub of the needle, you're done. You just pull everything out. You don't try to put the stylet back in the needle. You just pull the needle right out. There's no reason to put the stylet in. It's a practice that I've never really understood, but I never try to put the stylet back in. So in regards to our study, we had a medical student utilizing a radiology report search tool in the PACS system to identify all patients who received conventional fluoroscopic guided cervical nerve root blocks, utilizing this method, which I designed from the period of 2011 to 2018. We collected the data. We didn't get around to writing the paper till 2020, coincidentally during the whole COVID situation, which a lot of people wrote a lot of papers that year because we weren't doing much else. So all patients had to have a procedural report and post-procedural follow-up clinic visit of at least 2 weeks post-injection, and those were included. The benchmark for pain relief was greater than 50% reduction in pain, and this benchmark is used in multiple studies. So there were 254 successful fluoroscopically guided cervical nerve root blocks. There were no unsuccessful ones. This was all the patients we found, basically. These are stratified based on presence of pre-procedural pain. Yes, 246 of them. No, a number 8. These people had numbness or paresthesias in their arm. Those patients, the 8 patients, 7 of them had complete resolution of radiculopathy at 2 weeks, and 1 was unimproved. Of the patients who did have pain, those who had greater than 50% pain relief at 15 minutes, a number 185 or 75%, of those, 75% of those had maintenance of pain reduction from baseline at 2 weeks. and 25% approximately, their pain returned to baseline. For those patients who didn't have at least 50% pain relief at 15 minutes, 61 patients, at 2 weeks, about 43% of those actually did have greater than 50% pain relief at 2 weeks. So just because they don't have pain relief initially doesn't mean they're not going to get it. It's not quite 50%, but it's a significant number of them that actually have pain relief. And then the other 57% didn't improve. This is just a table that basically says the same stuff, and then it just lists a few of the minor adverse events, which I'll discuss later. So at greater than 2 weeks, 172 of the 254 patients, or 67.7%, reported a greater than 50% reduction in usual pain or complete alleviation of paresthesias. This investigation supports the supposition that conventional fluoroscopic guided selective cervical nerve root blocks, when performed by an experienced provider with meticulous technique, are equivalent in safety and efficacy compared to existing CT guided cervical nerve root block publications, and several listed in that publication. We had no severe adverse events, and we continue to have no severe adverse events reported since we established our conventional fluoroscopic guided practice. This study only had like 254 patients. We've done over 1,000 now between me and a couple other providers that I've taught this procedure to. And we've had no major adverse events. Some of the minor events, our study had a minor adverse event rate comparable to many other studies. Ours was 5.5%. These range from 4 to 6%. So we were right in the middle of that. So you can have mild injection site pain, lightheadedness on standing, increase in usual pain in a familiar distribution. The transient pseudo-Horner syndrome that I was mentioning, we had one patient with that. And like I was saying, it's inadvertent epidural injection and blockage of sympathetic fibers at C8 and T1. What had happened was during the injection, this was before I started leaving my needle right at the edge of the lateral mass. I injected, didn't see any vascular filling, but saw subtle epidural filling. So I just backed my needle out a ways and I re-injected, and I didn't feel like the epidural component increased. So I went ahead and injected anyway. After the procedure, everything was fine. The patient went to the recovery area, and then they happened to go to the bathroom and look in the mirror, and they had meiosis in the eye on the same side that the injection was performed. And basically after 30 minutes, it resolved. But it was one of those things you don't want to do. So that's one of the main reasons I don't put my needle any further in than just the edge of the lateral mass. And then other minor adverse event, new onset diffuse headache. We had a few people with that. So conventional fluoroscopy compared to CT, conventional fluoroscopy is generally more cost effective. It's reported to be faster. In today's world, if you've been doing a lot of CT guided procedures, you may be quick, but in my experience doing a fluoroscopic procedure versus doing a CT procedure, it's much faster with fluoroscopy. I can say I do a lot of biopsies, like vertebral body biopsies, and doing one under conventional fluoro versus doing one under CT, I can do the one in conventional fluoro like in half the time. So I'm confident that it is indeed faster than CT guidance. Conventional fluoroscopy has a smaller dose of radiation. Just for an example, in our study, our average time of fluoro was 24.3 seconds. And it's reported in the literature, it's confirmed in the literature that it's a smaller dose of radiation. That being said, back in 2019, this paper was produced. It was actually for CT-guided lumbar steroid injections, which I'm not sure who does those, but obviously some people do them. and they compared the radiation exposure for the patient, for the provider, et cetera, et cetera. But if you read the study design seems to be slanted to produce this outcome. Because in their study, the CT operator stood behind the gantry, not next to the patient during CT fluoroscopy. Like I said, I've done a lot of CT biopsies. I have never stood behind the gantry. I don't know if normal people do that, but I've never seen anybody do that before. And we have a pretty busy CT guided practice for all kinds of different biopsies. They also, when they were doing conventional fluoroscopy, they had the operator standing next to the patient for conventional fluoroscopy and utilize a plastic forceps to steer the needle under continuous fluoroscopy. Number one, this is horribly bad form. Number two, there's no reason to do that. And number three, yeah, you're going to have a lot of radiation exposure to your hand if your hand's in the beam of the fluoro. In our practice, the only real-time exposure is during the live contrast injection, and our hand's not in the fluoro. It's outside the fluoro because of the extra tubing, and it's scatter radiation that we're getting, and that's when we have exposure. So it doesn't really apply. This study doesn't apply to our practice. There's other people out there that are suggesting the use of digital subtraction angiography. A recent study came out and said that the detection rate of intravascular injection during real-time fluoroscopy shows no substantial statistical difference compared to the detection rate during digital subtracted angiography. We don't use it in our practice. We don't feel we need it. We've never had a problem with it. So some limitations to the study. It was retrospective. It also requires the patients to subjectively report their pain. Obviously, well, that's pretty much every study that studies pain. The injection level in our population are generally in the mid to lower cervical spine. You can't really generalize to the upper cervical nerve root injections, which I would not perform a C1 or C2 nerve root. And when I do a greater occipital nerve block, I don't use this technique. I use a different technique. This did not account for the severity of the stenosis, and it was, like I said, it was my patients. It was a single proceduralist. So conclusions: there were no serious complications in our study. The ability to assess real-time intravascular invasion paired with the use of a non-particulate steroid in our experience renders conventional fluoroscopic guidance along with dexamethasone-based injection the safest and most efficient option. We had a low incidence of minor complications, which was well within the normal range. And CT lacks meaningful superiority in efficacy or safety and has drawbacks, including cost, radiation, time, etc. So in our mind, conventional fluoroscopy is the favorable technique in our practice. I have all my references at the end of the paper and at the end of the presentation.